Hello, this is Part 5, Image Analysis of the Skeletal System. We're going to look at various diseases, disorders, some tumors, bone metastases, fractures, and conclude with some fractures, dislocations, and conditions of the spine. We're going to begin with congenital hereditary diseases of bone.
The first thing we'll explore are some vertebral anomalies. A transitional vertebra is one that has characteristics of vertebrae on both sides of a major division of the spine. Transitional vertebrae most frequently occur at the lumbosacral junction and contain expanded transverse processes which may form actual unilateral or bilateral joints with the sacrum. In comparing an AP projection of the lumbar spine with negative findings with that of a person with a transitional vertebra, we can see the expanded transverse processes at the lumbosacral junction. When the condition is unilateral, this process often leads to degenerative change involving the opposite hip and the intervertebral disc space above it. At the thoracolumbar junction, the first lumbar vertebra may have rudimentary ribs articulating with the transverse processes. The seventh cervical vertebra may also have a rudimentary rib. In comparison with an image in which there are negative findings or normal findings, we see bilateral cervical ribs in the image shown here. A cervical rib may compress the brachial nerve plexus, causing pain or numbness in the upper extremity or the subclavian artery, which decreases blood flow to the arm, and therefore requires surgical removal.
Spina bifida refers to a posterior defect of the spinal canal resulting from failure of the posterior elements to fuse properly. A mild insignificant form is spina bifida occulta, in which there is a splitting of the bony neural canal at the L5 or S1 level. Large defects are associated with spinal cord abnormalities and may lead to a variety of muscular abnormalities and lack of bladder or bowel control. Large defects in the lumbar or cervical spine may be accompanied by a meningocele or a myelomeningocele. A patient with a meningocele may be asymptomatic. Spina bifida lesions are associated with large bony defects, absence of the laminae, and increase in interpedicular distance. The herniated spinal contents are seen as a soft tissue mass posterior to the spine. Myelography, CT, or MRI can demonstrate the presence of spinal cord or nerve roots within the herniated sac. Prenatal real-time ultrasound can demonstrate the serious malformation in utero on sagittal spine fetal images that determine the location and severity of the deformity. Osteoporosis is also referred to as marble bones. It is a rare hereditary bone dysplasia in which failure of the resorptive mechanism of calcified cartilage interferes with the normal replacement by mature bone. It prevents the bone marrow from forming so that the bones become very brittle and stress fractures often occur. Comparing the normal image to the patient who has osteoporosis, you can notice the striking sclerosis of the bones of the hand and wrist. Here's another image comparing a patient with osteoporosis with a patient who has negative findings. In the patient with osteoporosis, we can see generalized increased bone density of the lower spine, pelvis, and hips. Osteogenesis imperfecta, also referred to as brittle bones. This is an inherited generalized disorder of connective tissue characterized by multiple fractures and an unusual blue color of the sclera. Due to imperfectly formed or inadequate bone collagen, the adult patient with OI is generally wheelchair-bound because the skeletal structure does not support the body weight. We have an AP and lateral projection of an adult patient in which we can visualize the demineralization and the lack of bony cortices that are demonstrated. The fractures that occur in a patient with OI often heal with exuberant callus formation, so extensive many times as to simulate a malignant tumor, sometimes causing bizarre deformities. In the AP projection of the thorax and abdomen, otherwise referred to as a babygram, note the generalized flattening of the vertebral bodies associated with fractures of multiple ribs and long bones. Ossification of the skull progresses slowly, leaving wide sutures and multiple juxtasutural accessory bones within a suture referred to as wormian bones that produce a mosaic appearance. Something that occurs commonly with OI is that child abuse can be confused with this condition because the presentation of multiple fractures in different stages of the healing process.
The aim of treatment for osteogenesis imperfecta is to reduce fractures by using proper safety measures. Because of defective cortices in severe cases, the long bones become less supportive. Therefore, in some instances, extendable rods are surgically placed to provide more support, help prevent new fractures from occurring, and prevent long bone bowing. Currently, pharmaceuticals are prescribed to regulate the osteoclastic formation and thus keeping the bone density more normal. As research continues, stem cell transplants may become a viable cure. Achondroplasia, which is the most common form of dwarfism, is caused by the diminished proliferation of cartilage in the growth plate. Some radiographic findings include that of the spine. The radiographs of the spine will show narrowing of the space between the pedicles with scalloping of the posterior margins of the lumbar vertebra. CT is beneficial in demonstrating the degree of spinal narrowing caused by spondylolysis and changes in the vertebral column. There are physical characteristics that a person or individual with achondroplasia would have, but also there are changes radiographically in terms of the pelvis. And if we look at the AP projection of the pelvis on the left-hand side in a patient with negative findings and compare that with the image on the right of a person with achondroplasia, note the femoral head deformity caused by decreased endochondral bone formation. Congenital hip dysplasia. This is also known as developmental hip dysplasia, and it results from incomplete acetabulum formation. It's more common in females than males, and upon pediatric assessment of the hip, when the leg is flexed and abducted, the hip may pop out of joint and a click is felt or heard. Tendon and ligaments responsible for proper femoral head alignment are, of course, affected. Now, looking at the images shown here, I thought I'd point out the shielding that was used in the AP projection of the infant in the top image with negative findings, and then in the image below, note the hip dysplasia in a 2-year-old child. This was a cleaves or frog leg view of the pelvis, which the legs were abducted, and demonstrates superior and posterior displacement. Let's next look at inflammatory and infectious disorders. Rheumatoid arthritis is a chronic systemic disease of unknown cause that appears primarily as a non-suppurative inflammatory arthritis of the small joints of the hands and feet. Women are affected about 3 times more frequently than men, and the average age at onset in adults is 40 years. The earliest radiographic evidence of rheumatoid arthritis is fusiform periarticular soft tissue swelling caused by joint diffusion and hyperplastic synovial inflammation. Disuse and local hyperemia lead to periarticular osteoporosis, which we can see in the image on the patient on the right-hand side, that initially is confined to the portion of the bone adjacent to the joint but may extend to involve the entire bone. In the end stage of the disease, rheumatoid arthritis appears radiographically with severe bilateral systemic destructive changes of the hands and wrists with striking subluxations. In the cervical spine, rheumatoid arthritis characteristically produces atlantoaxial subluxation. This results from weakening of the transverse ligaments from synovial inflammation. A routine lateral image of the cervical spine shows a normal relationship between the anterior border of the odontoid process and the superior portion of the anterior arch of the atlas. Notice in the same patient and the lateral projection with flexion that there's a wide separation between the anterior arch of the atlas and the odontoid. And this is consistent with subluxation. Synovitis is something that's not demonstrated on plain radiographs. It requires MRI. So we're looking at two MRI images in the coronal plane. The image on the left is a T1 weighted image in a patient with negative findings. On the right, we see a T2 weighted image in a patient with synovitis. Notice the high signal or strong signal at the areas of the joints, and in particular, notice the fifth proximal phalanx in the medial border and the entire fifth metacarpal phalangeal joint. Ankylosing spondylitis, which is a type of rheumatoid arthritis, almost always begins in the sacroiliac joints, causing bilateral and usually symmetric involvement. Blurring of the articular margins and patchy sclerosis generally progress to narrowing of the joint space and may lead to complete fibrosis and bony ankylosis. The disease typically progresses from the lumbar spine upward. Ossification in the paravertebral tissues and longitudinal spinal ligaments combines with extensive lateral bony bridges between the vertebral bodies to produce the characteristic bamboo spine of advanced disease. And we can see the severe vertebral fusion that illustrates that bamboo spine. Limitation of movement in patients with ankylosing spondylitis leads to generalized skeletal osteoporosis and a tendency to fracture in response to the stress of minor trauma. We can see an oblique fracture of the mid-cervical spine with anterior dislocation of the superior segment is seen in a patient who fell while dancing and struck his head. The fracture extends to the lateral mass and the lamina. Reiter's syndrome, which is a reactive arthritis, is characterized by arthritis, urethritis, and conjunctivitis. It primarily affects young adult males and appears to occur after certain types of venereal or gastrointestinal infections. Reiter's syndrome most frequently involves the sacroiliac joints, the heel, and the toes. We can see striking bony erosion and insertion of the Achilles tendon on the posterior-superior margin of the calcaneus. Reiter's syndrome primarily affects the feet rather than the hands. We're looking at two AP projections of the toes that were performed in two different patients. On the left-hand side, we're looking at that of a patient with negative findings. In the image on the right, we're looking at a patient in which the image was magnified, but the patient has Reiter's syndrome. Notice the erosive changes about the metatarsal phalangeal joint of the fifth digit. Erosions involve the juxtaarticular region, leaving the articular cortex intact. Psoriatic arthritis is a rheumatoid-like destructive process involving peripheral joints that develops in patients with typical skin changes of psoriasis. In the PA projection of the hand, notice the bizarre pattern of asymmetric bone destruction, subluxation, and ankylosis. Notice the particularly severe pencil and cup deformity of the third proximal interphalangeal joint and the bony ankylosis involving the wrist and phalanges of the second and fifth digits. Then, in the patient on the right-hand side, which is an AP oblique projection of the foot, notice the severe mutilating arthritis of the foot shown here. There's extreme pencil-like destruction of the metatarsals and phalanges with ankylosis of almost all tarsal joints. Osteoarthritis, otherwise referred to as degenerative joint disease, is an extremely common generalized disorder characterized pathologically by loss of joint cartilage and reactive new bone formation. The earliest radiographic findings in DJD, are narrowing of the joint space caused by thinning of the articular cartilage and development of small bony spurs, otherwise referred to as osteophytes. In the fingers, degenerative joint disease involves primarily the distal interphalangeal joints. Marginal spurs produce well-defined bony protuberances that appear clinically as palpable and visible knobby thickening. In the hip, the most prominent finding is asymmetric narrowing of the joint space that involves predominantly the superior and lateral aspects of the joint where the greatest stress of weight bearing exists. Also note the sclerotic bone reaction that is noted by the white areas or lighter areas on the image. Joint space narrowing is also symmetric in the knee, where it predominantly involves the medial femoral tibial compartment. Osteoarthritis of the shoulder is well visualized in the AP oblique projection or Grassi method. Notice the open glenoid cavity on the left-hand side, and then the right, notice the narrowing of that cavity as well as erosion. Infectious arthritis is one in which there are pyogenic organisms that enter a joint by the hematogenous route, osteomyelitis, trauma to the joint, or surgery. Onset is abrupt with fever, chills, and tender swollen joints. Now, radiographic findings or appearances are important to note here. The very first sign will be soft tissue swelling. Then we'll see periarticular edema that displaces or obliterates tissue fat planes. The earliest bone tissue changes will be small focal erosions in the articular cortex. And finally, severe untreated infections will cause extensive destruction and the loss of entire cortical outline. An example of a patient with infectious arthritis is provided on this slide. Several days after instrumentation of the shoulder for joint pain, there is separation of the humeral head from the glenoid fossa caused by fluid in the joint space. 6 weeks later, pronounced cartilage and bone destruction are evident with sclerosis on both sides of the glenohumeral joint. And this is consistent with septic arthritis. In that same patient, we can see on a radionuclide scan there's a focal area of increased activity in the right shoulder that correlates with the clinical history of septic arthritis. TB arthritis is most commonly found in patients with pulmonary TB. It usually affects one joint and it affects primarily the spine, hips, and knees. An early radiographic feature of TB arthritis is extensive juxta-articular osteoporosis that precedes bone destruction. Secondly, joint diffusion leads to nonspecific periarticular bone tissue cartilage. In the later stages of this disease, cartilage and bone destruction occur and tend to initially involve the periphery of the joint, sparing the maximal weight-bearing surfaces that are destroyed in pyogenic arthritis. Compared to the lateral projection of the elbow in a patient with negative findings, notice the lateral projection in a patient with TB arthritis of the elbow with complete destruction of the joint space. Treatment of arthritis involves first-line medications such as nonsteroidal anti-inflammatory drugs. Secondly, aspirin and ibuprofen. Third, antiarrhythmic drugs. And finally, invasive surgery that involves replacing joints with new artificial joints. In the PA projections of the patient shown here, we can see dislocation and joint destruction of the 2nd to the 5th metacarpal phalangeal joints. In the post-operative image of the same patient, with the digits fully extended, it illustrates the 2nd through 5th metacarpal phalangeal joint implants. Bursitis refers to inflammation of the bursae. Repeated physical activity commonly causes bursitis, but trauma, rheumatoid arthritis, gout, or infection can also cause this inflammation. The major radiographic manifestation of bursitis is deposition of calcification in adjacent tendons, which is a common cause of pain, limitation of motion, and disability about a joint. Calcific tendinitis most commonly involves the shoulder, and calcification may be demonstrated radiographically in about half the patients with persistent pain and disability in the shoulder region. However, calcification may also be detected in asymptomatic patients, and severe clinical symptoms may occur without evidence of calcification. Osteomyelitis is an inflammation of the bone and bone marrow caused by a broad spectrum of infectious organisms that reach bone by hematogenous spread, by extension from an adjacent site of infection, or by direct introduction of organisms after trauma or surgery. Because the earliest changes of osteomyelitis are usually not evident on plain radiographic images until about 10 days after the onset of symptoms, radionuclide or nuclear medicine with technetium-99 bone scanning is the most valuable imaging modality for the early diagnosis of osteomyelitis. Increased nuclide uptake, reflecting the inflammatory process and increased blood flow, is evident within hours of the onset of symptoms. On plain radiographs, the earliest evidence of osteomyelitis in a long bone is localized deep soft tissue swelling adjacent to the metaphysis. The initial bone changes appear as subtle areas of metaphyseal lucency, reflecting resorption of necrotic bone. Soon, bone destruction becomes more prominent, producing a ragged, moth-eaten appearance. These are AP projections of a patient's foot that were magnified, and we can see in the initial image of the first metatarsal phalangeal joint that shows soft tissue swelling and periarticular demineralization caused by increased blood flow to the region. On the right, we can see an image that was performed several weeks later, and that there's severe bony destruction about the metatarsal phalangeal joint that can be seen. The more virulent the organism, the larger the area of destruction. Subperiosteal spread of inflammation elevates the periosteum and stimulates the deposition of layers of new bone parallel to the shaft. This results in a layered periosteal reaction that is characteristic of benign diseases, especially infection. Eventually, a large amount of new bone surrounds the cortex in a thick, irregular, bony sleeve referred to as an involucrum. Disruption of cortical blood supply leads to bone necrosis. Segments of avascular dead bone or sequestra remain as dense as normal bone and are clearly differentiated from the demineralized bone, infected granulation tissue, and pus around them. After the acute infection has subsided, a pattern of chronic osteomyelitis develops. The bone appears thickened and sclerotic with an irregular outer margin. The cortex may become so dense that the medullary cavity is difficult to demonstrate. The earliest sign of vertebral osteomyelitis is subtle erosion of the subchondral bony plate with loss of the sharp cortical outline. This may progress to total destruction of the vertebral body associated with the perivertebral soft tissue abscess. In the image shown here, we see narrowing of the intervertebral disc with irregularity at the end plates and reactive sclerosis. TB osteomyelitis, which is rare today, most commonly involves the thoracic and lumbar spine. POTS disease, which is tuberculosis of the spine, occurs in the mid-thoracic and thoracolumbar region. Irregular, poorly marginated bone destruction within the vertebral body is often associated with the characteristic perivertebral abscess. The spread of infection causes narrowing of the adjacent intervertebral disc and the extension of infection and bone destruction across the disc to involve the adjacent vertebral body. Unlike bacterial infection, tuberculosis osteomyelitis is rarely associated with periosteal reaction or bone sclerosis. The initial image demonstrates vertebral collapse and anterior wedging of the adjacent mid-thoracic vertebrae. Residual intervertebral disc space can barely be seen. In an image obtained several months later, there is virtual fusion of the collapsed vertebral bodies, producing the characteristic sharp kyphotic angulation. We're now going to look at metabolic bone disease. Osteoporosis or porous bone is a generalized or localized deficiency of bone matrix in which the mass of bone per unit volume is decreased in amount but normal in composition. It is usually caused by accelerated resorption of bone, although decreased bone formation may lead to osteoporosis in some situations, for example in Cushing syndrome after prolonged steroid administration and after prolonged disuse or mobilization as in a casted extremity. The example shown here involves severe periarticular demineralization after prolonged immobilization of the hand. And notice the porous appearance of the bone at the areas of the joints. Dual energy X-ray absorptiometry or DEXA bone densitometry provides data that measures bone mineral content. It's used to image the hip and spine, assisting in the determination of bone quality. The patient's history is entered into a computer system and 2 images, usually an AP lumbar spine and AP hip, are taken. The image data are compared with those of other individuals of the same race, age, and weight to determine a bone quality value. This value indicates whether a patient has normal bone, osteopenia, or osteoporosis. The patient on the left-hand side had a T-score of 3.3, which demonstrated osteoporosis. The image on the right-hand side is a dual femur of the 65-year-old woman with a T-score average of 2.3, indicating osteopenia. One of the treatments used to prevent vertebral collapse in patients with osteoporosis is a vertebroplasty, and these AP and lateral projections were performed of the thoracolumbar region on an 81-year-old woman after she had vertebroplasty. Osteomalacia, referred to as softening of bone, refers to a decrease or insufficient mineralization of the adult skeleton due to a lack of calcium and phosphorus. We're looking at a lateral projection of the thoracolumbar region, and notice the striking prominence of the cortices of the vertebral bodies with increased tuberculation of the spongy bone. Causes of osteomalacia are vitamin D deficiency or renal disease. Notice in this image is an AP projection of the hip that's magnified to visualize protrusio acetabuli as seen in osteomalacia and also in patients with Paget's disease. Rickets is a systemic disease in children that's similar to osteomalacia in adults. The cause is a lack of vitamin D in the diet of infants and children. In this condition, there's bone softening with bowing of the weight-bearing bones, especially the tibia, and development of kyphosis. These are PA projections of a child's wrist. The initial image shows characteristic cupping and fraying of the metaphyseal ends of the radius and ulna with the disappearance of normally sharp metaphyseal lines. On an image obtained after therapy with vitamin D, there is remineralization of the metaphyseal ends of the radius and ulna, increased sharpness of the metaphyseal lines, and a return of the epiphyseal centers to normal density and sharpness of outline. Gout is a disorder in the metabolism of purine in which an increase in the blood level of uric acid leads to the deposition of uric acid crystals in the joints, cartilage, and kidney. Acute gout manifests primarily as an exquisitely painful arthritis that initially attacks a single joint, usually the first metatarsal phalangeal joint. These images are AP oblique projections of the foot, where they've magnified them to demonstrate gout. In the image we can see effusion with tophi deposits as the first, fourth, and fifth metatarsal phalangeal joints. Deposition of non-opaque urate crystals in the joint synovial membrane and on the surface of articular cartilage incites an inflammatory reaction that produces the earliest radiographic signs of joint effusion and periarticular swelling. In this image of the lateral projection of the finger, we can see the severe joint diffusion and periarticular swelling of the proximal interphalangeal joint of the finger. Note the associated erosion of the articular cartilage. Continued deposition of urate crystals in the periarticular tissues causes the development of the characteristic large, lumpy, soft tissue swellings representing gouty tophi. In addition to the first metatarsal phalangeal joints, other common sites of tophi are the ear, olecranon bursa, and insertion of the Achilles tendon. Tophi, consisting of only sodium urate, appear as soft tissue densities. Deposition of calcium in these urate collections causes the periarticular masses to become radiopaque. In the advanced stage of gout, there are severe destructive lesions. There are two examples shown here of typical rat bite erosions about the first metatarsal phalangeal joint. The cyst-like lesions have thin sclerotic margins and characteristic overhanging edges. Paget's disease is one of the most common chronic metabolic diseases of the skeleton. It involves a destructive process followed by a reparative process that results in weakened, deformed, and thickened bony structures that tend to fracture easily. The radiographic appearance in the early stage is the lytic process, or destruction of bone. In the skull, it begins as an area of sharply demarcated radiolucency that represents the destructive phase of the disease. During the reparative process, the development of irregular islands of sclerosis and cortical thickening results in a mottled cotton wool appearance. A nuclear medicine bone scan is the most efficient method to visualize multicentric lesions. A bone scan demonstrates cold spots representing the initial destructive phase and hot spots as a result of the reparative process. The pelvis is the most common and often the initial site of Paget's disease. A distinctive early sign is coarsening of the trabeculae along the iliac margins, which causes thickening of the pelvic brim. In the long bones, the destructive phase almost invariably begins at one end of the bone and extends along the shaft for a variable distance before ending in a typical, sharply demarcated V-shaped configuration. In the reparative process, the bone is enlarged with a irregularly widened cortex and coarse, thickened trabeculae. Lead poisoning results from ingestion of lead-containing materials, especially paint, or from the occupational inhalation of lead fumes. In children, because lead and calcium are used interchangeably by bone, high concentrations of lead are deposited in the most rapidly growing portions of the skeleton, especially the metaphyses at the distal ends of the femur. This results in the classic lead lines, which are dense transverse bands extending across the metaphyses of the long bones and in the margins of the flat bones, such as the iliac crest. In young children who eat lead-containing paint, plain abdominal radiographs, or KUB, may show extensive mottled opacities that are suggestive of intestinal barium, even though no contrast material had been administered. Fibrous dysplasia, a disorder that usually begins during childhood, is characterized by the proliferation of fibrous tissue within the medullary cavity. This proliferation causes loss of trabecular markings and widening of the bone. Fibrous replacement of the medullary cavity typically produces a well-defined radiolucent area, which may vary from completely radiolucent to a homogeneous ground glass density, depending upon the amount of fibrous or osseo tissue deposited in the medullary cavity. Irregular bands of sclerosis may cross the cyst-like lesion, giving it a multilocular appearance. The bone is often locally expanded, suggesting a balloon, and the cortex may be eroded from within, predisposing to pathologic fractures. In severe and long-standing disease, affected bones may become bowed or deformed. In the AP projection of the proximal humerus, we can see an expansive lesion of the humerus contains irregular bands of sclerosis, giving it a multilocular appearance. Ischemic necrosis of bone is caused by the loss of blood supply, which in turn can result from such varied conditions such as thrombosis, vasculitis, disease of surrounding bone, and single or repeated episodes of trauma. The femoral head is the most common site of ischemic necrosis. Initially, the ischemic bone might appear denser than the adjacent viable bone. The first sign of structural failure is the development of a radiolucent subcortical band, referred to as a crescent sign, representing a fracture line. As the disorder progresses, fragmentation, compression, and resorption of dead bone, along with proliferation of granulation tissue, revascularization, and production of new bone, produce a pattern of lytic and sclerotic areas with flattening of the femoral head and periosteal new bone formation. MRI can also be used to detect ischemic necrosis. In the image on the left, we see a T1 weighted image in which we see the ischemic right femoral head has lost its normal bright homogeneous signal intensity and appears dark and mottled. And on the T2 weighted image, the affected area appears as a bright signal intensity representing edema. In addition to ischemic changes in the subchondral areas of bone, infarction may involve the shaft of a long bone. In many cases, this type of bone infarction is asymptomatic and is detected only on radiographs obtained for another purpose. A mature infarct in the shaft of a bone appears as a densely calcified area in the medullary cavity. It may be sharply limited by a dense sclerotic lesion or associated with dense streaks extending from the central region. Benign bone neoplasms generally display soft tissue, whereas malignant bone tumors produce true soft tissue swelling. When there is bone expansion, an infarct cortex with a sclerotic margin usually indicates a benign lesion. An osteochondroma or exostosis is a benign projection of bone with a cartilaginous cap that arises in childhood or the teen years, especially about the knee. The exostosis occurs in the epiphyseal plate and grows laterally from the epiphysis. A true osteochondroma must exhibit the cortex and medullary portion as continuous bone growth. A radiograph is the preferred method to demonstrate that the cortex of an osteochondroma blends with that of normal bone. The long axis of the tumor characteristically runs parallel to the parent bone and points away from the nearest joint. An endochondroma begins as a slow-growing, benign cartilaginous tumor arising in the medullary canal. This tumor destroys normal bone by erupting as a mixture of calcified and uncalcified hyaline cartilage. Endochondromas are most frequently found in children and young adults, and they involve primarily the small bones of the hands and feet. As the well-demarcated tumor grows, it expands bone locally, causing thinning and endosteal scalloping of the cortex. This process often leads to a pathologic fracture with only minimal trauma. A giant cell tumor, osteoclastoma, typically arises at the end of the distal femur or proximal tibia of a young adult after epiphyseal closure at ages 20 to 40 years of age. It begins as an eccentric lucent lesion in the metaphyses, and it characteristically extends to the immediate subarticular cortex of the bone but does not involve the joint. As a tumor expands toward the shaft, it produces the characteristic radiographic appearance of multiple large bubbles separated by thin strips of bone. Osteomas most often arise in the outer table of the skull, the paranasal sinuses, and the mandible. Detection of these tumors may be incidental on radiographs taken because of the pain produced by bone expansion. Osteomas appear radiographically as well-circumscribed, extremely dense, round lesions that are rarely more than 2 centimeters in diameter. Osteoid osteomas usually develop in teenagers or young adults and produce the classic clinical symptom of local pain that is worse at night and is drastically relieved by aspirin. Most of these tumors occur in the femur and tibia, originate from osteoblastic cells, and are less than 1.5 centimeters in diameter. The tumor is typically seen as a small, round, or oval, lucent center less than 1 centimeter in diameter that are surrounded by a large, dense sclerotic zone of cortical thickening. A simple bone cyst is a true fluid-filled cyst with a wall of fibrous tissue that most often appears in the proximal humerus or femur at the metaphyses. Although not a true neoplasm, a simple bone cyst may resemble one radiographically and clinically. Solitary bone cysts are asymptomatic and often discovered either incidentally or after pathologic fracture. The simple bone cyst appears as an lucent lesion that is sharply demarcated from adjacent normal bone and may have a thin rim of sclerosis around it. It has an oval configuration with its long axis parallel to that of the host bone and may cause cortical bone thinning. An aneurysmal bone cyst, also referred to as a hemangioma, consists of numerous blood-filled arteriovenous communications thought to be caused by trauma. In long bones, an aneurysmal bone cyst is an expansile, eccentric, cyst-like lesion that causes pronounced ballooning of the thin cortex. Because severely thin cortex is difficult to detect, the tumor resembles a malignant process. Bone islands are solitary, sharply demarcated areas of dense, compact bone that occur most commonly in the pelvis and upper femur. They appear in every bone except the skull. Although almost half of the bone islands enlarge over a period of years and many show activity on radionuclide scans, bone islands are asymptomatic and completely benign and must be distinguished from osteoblastic metastases. Malignant bone neoplasms generally cause soft tissue swelling and cortical bone erosion with a margin that is poorly defined or absent. The neoplasm extends into the soft tissue through spiculations, which are finger-like projections. Plain radiographs may identify a single lesion. A nuclear medicine bone scan or PET scan can detect silent lesions when minimal cellular destruction has occurred. CT and MRI can precisely define the location of a malignant bone tumor and its extension into the medullary cavity and spread to surrounding structures. Osteosarcoma, otherwise referred to as osteogenic sarcoma, generally occurs in the end of a long bone in the metaphyses, especially about the knee. This tumor consists of osteoblasts, which produce osteoid and spicules of calcified bone. In the CT axial slice through the level of the femoral head, it demonstrates destruction of the left ischium, which was seen on plain radiographs. In addition, the CT scan demonstrates a large soft tissue mass in the area covered by the gluteus maximus muscle and separated from the rectum. The mass was not clinically palpable. In the MRI scan of osteogenic sarcoma, we can see a coronal image that shows the intramedullary and soft tissue extent of the mass. Most osteogenic sarcomas arise in persons between 10 and 25 years of age, although a smaller peak incidence is seen in older persons who have a pre-existing bone disorder, particularly Paget's disease. The typical radiographic appearance of osteogenic sarcoma is a mixed destructive and sclerotic lesion associated with a soft tissue mass, irregular periosteal reaction, and reactive new bone formation. In the classic sunburst pattern, horizontal bony spicules extend in radiating fashion into the soft tissue mass. A chondrosarcoma is a malignant tumor of cartilaginous origin that may originate anew or within a pre-existing cartilaginous lesion. In addition to the bony destruction seen with all malignant tumors, chondrosarcoma often contains punctuate or amorphous calcification within its cartilaginous matrix. And in this image we see a rather large chondrosarcoma in the posterior aspect of the distal femur. Ewing sarcoma is a primary malignant tumor arising in the bone marrow of long bones. It's a tumor of children and young adults. Ewing sarcoma has a peak incidence in the mid-teens and is rare in persons over 30 years of age. The classic radiographic appearance of Ewing sarcoma is an ill-defined permeative area bone destruction that involves a large central portion of the shaft of a long bone, with underlying medullary destruction, and is associated with the fusiform layered periosteal reaction, otherwise referred to as an onion skin appearance parallel to the shaft. Multiple myeloma is a disseminated malignancy of plasma cells that may be associated with bone destruction, bone marrow failure, hypercalcemia, renal failure, and recurrent infections. The disease affects persons between 40 and 70 years of age. The classic radiographic appearance of multiple myeloma is multiple punched-out osteolytic lesions scattered throughout the skeletal system and best seen on lateral projections of the skull. In the AP projection of the proximal femur, there's a diffuse destructive bone lesion that has led to a pathologic fracture of the femur. In the lateral projection of the thoracolumbar region, there's diffuse myelomatous infiltration that has caused generalized demineralization of the vertebral bodies and a compression fracture of L2. The severe loss of bony substance in the spine often leads to multiple vertebral compression fractures. PET imaging helps to determine therapy effectiveness by demonstrating active tumor metastases in multiple myeloma. The PET oncological survey findings are positive, with a pattern of extensive metabolically active tumor metastases demonstrated throughout the axial skeleton and in both lower lung fields on a coronal and transverse image. After 4 months, when the patient is in his last cycle of chemotherapy, the survey images shown here demonstrate persistent, viable, metabolically active neoplasm. However, a drastic improvement in the overall pattern in comparison with the earlier scan is seen. Metastases are the most common malignant bone tumors, spreading by means of the bloodstream or lymphatic vessels or by direct extension. The most common primary tumors are carcinomas of the breast, lung, prostate, kidney, and thyroid. Favorite sites of its metastatic spread are bones containing red marrow, such as the spine, pelvis, ribs, skull, and the upper ends of the humerus and femur. The image on the left-hand side is a screening radionuclide bone scan. There are multiple focal areas of radionuclide uptake in the axial skeleton representing metastases from prostate carcinoma. In the image on the right, we see a fluorodeoxyglucose PET scan showing metastases. The arrows are pointing to metabolic activity in the skeletal system, specifically the ribs. Metastatic disease may produce a broad spectrum of radiographic appearance, which include osteolytic, sclerotic, or mixed. Osteolytic metastases cause destruction without accompanying bone proliferation. They develop from tumor embolic deposits in the medullary canal and eventually extend to destroy cortical bone. In the AP projection of the pelvis, we see a lytic expansile destruction of the ileum in a patient with metastatic thyroid carcinoma. On the right, we see a lytic metastases to the humerus from a carcinoma of the kidney. In both of these cases, the osteolytic bone metastases are referred to as a blowout. Osteoblastic bone metastases is the opposite of osteolytic. Osteoblastic refers to a slow growth in a neoplasm that allowed for proliferation of reactive bone. There is increased tissue density or bone density in this case. In the AP projection of the pelvis, there are multiple areas of increased density involving the pelvis and proximal femurs, representing metastases from carcinoma of the urinary bladder. On the right, we see an ivory vertebra, which is a situation in which we see increased bone density in only one vertebra. There's diffuse sclerosis of the L4 vertebral body from metastatic carcinoma of the prostate. These are both MRI images in the sagittal plane on patients with metastases. The image on the left is a sagittal image that shows gross metastatic destruction and replacement of the body of T2, which has collapsed. The metastases has a lower signal intensity than that of the vertebral marrow or the spinal cord. The spinal cord is focally indented and displaced posteriorly by the tumor. Also, a low signal intensity lytic metastases involves the anterior portion of T3. In the image on the right, we're looking at an MRI image of the lumbar region, and there's vertebral metastases from breast carcinoma, and there are many lytic lesions that are evident on this image. This concludes Part A on the skeletal system